Dear colleagues, thank you for the invitation to talk here about my experience with the pitch-patch in rotator cuff repair. The gold standard today, is mostly arthroscopically. We use suture anchors or transosseous fixation system. The fixation should be in single, double, or even triple row configuration, and often in combination with a suture bridge. But there are still limits. For example, irreparable cuff tears. That means you have a loss of tendon tissue, so you can't close the cuff. Or you have a bad outcome with bad tendon quality in all patients in the revision surgery, or you have also a bad outcome in massive rotator cuff tears because of the strong pull-out strength. Contraindication for a cuff repair in this case are osteoarthritis or a fatty infiltration of the muscles. In literature, we have to deal with the quite high re-rupture rate, depending on size and cause of the lesion from 10% up to 90%. That's why we developed in our unit the cloverleaf approach to these lesions. In young patients, mid-sized lesions, we try to repair. The normal standard repair, how I described. In cases where you have huge lesion, you have a loss of soft tissue, you can't close the lesion. In this case, we restore. We try to make a transfer of tendon, for example, latissimus dorsi, pectoralis major, or often today with allografts. In cases you can't close it, and these are often cases in revision surgery, in massive rotator cuff tears, or in old patients with a very soft, very weak tendon quality, we try to reinforce the repair. And in cases where you can't repair and you shouldn't, for example, osteoarthritis, fatty infiltration degree 3 and more in old patients, there we replace. In literature, there is an interesting study regarding human tendinocyte reacting on different grafts. Because in a lot of studies, there is a difference between the really good results in animal studies and the sobering results in human studies. That's why they showed in this series the reaction on tendinocytes on different grafts, like cellular adhesion, proliferation, activity, and histology. They used different patches, biological patches, synthetic patches, resorbable patches, and the outcome was quite interesting. For sure, you had on biological patches faster response, a nice reaction, but all over there was in not one different patch ingrow of cell material into the patches till now. We started 2011 comparing study with 3 different patches with the minimal follow-up of 36 months. We made the follow-up with constant score, SSV, and also the radiological follow-up with the MRI. We used in this study on the inclusion criteria. We had massive rotator cuff tears, but also bad tissue quality, or old patient or revision patient. Exclusion criteria, like always, fatty infiltration, more than degrees 2, and osteoarthritis. As grafts, use as allograft, the graft jacket, most famous one from the United States, the biological matrix of human origin with different colored genes. From the synthetic patches, we use the Artelon, today not on the market. It was a slow degrading polyurethane. And as resorbable patch, the Restore xenograft from Johnson & Johnson, it was a totally resorbable implant, resorbed in 2 to 3 months. The results, first results, interesting. We had a tremendous increase in the constant score from around 40 up to over 80. In all the different patches, the same. In the group with the re-tear rate, we have seen there is a not significant, but a small difference that after 6 months they are weaker. We had certain complications. We had some foreign body reactions in all the different grafts, each one. But we have seen overall 24 re-ruptures. That means 29%, the highest re-rupture rate in the resorbable patches. In 5 cases, we had to we tried to re-repair it, but Justin's really satisfying results, and the other got all RCA. After that, we started a follow-up study. The design was more or less the same. It was a prospective cohort study, with all with the same patch. We had the same follow-up with constant score and subtractive shoulder value, but we had radiological follow-up with the MRI and long-term with the ultrasound. The final follow-up was more or less 4 to 5 years. Now we will talk a little bit about the technique. Here you have a case. This is a 52-year-old lawyer, very active karateka. He had 10 years ago a total supra-infraspinatus structure with a successful conservative treatment. Since 2 years, he remarked more and more night pain and a loss of strength. We have seen the patient with the clinical quite a good range of motion, but with the MRI, with the fat infiltration degree 3 in supraspinatus, at degrees 2 in infraspinatus, and with just a slight osteoarthritis. That's why we took the decision to start a repair. The patient was informed that we start a repair to try to close from one side to the other, to make margin conversion, to reduce the lesion, and if it's impossible, to change to a latissimus dorsi transfer. Here you see the mobility of the subscapularis was quite nice, and this is mostly a very important part. He had a rupture of the subscapularis, but no fat infiltration. That means often the mobility is quite good. We made the same approach on the posterior side after cleaning the tubercle. We put the posterior anchor in, and we tried to reduce the infraspinatus over the posterior anchor. I have to apologize, the movie has jumping a little bit, but you see, also here we tried from an outside-in technique to bring the infraspinatus tendon up to the superior part of the tubercle. So to close from posterior to anterior. You see here the soft tissue is, we have a lot of soft tissue, not very good quality, but we start to work with this quality. We have seen quite soon that mobility from posterior is not so bad. You can see we pull here on the posterior part of the tendon, and then we put one suture after the other through the tendon. In our experience, when you have a fat infiltration in infraspinatus less than degree 3, you get much more mobility than you thought, that you think in the first moment. You see here the mobility in this very active man is amazing, and it was quite helpful. And in this moment, because in the first moment we have, it was a discussion to change directly to the latissimus dorsi transfer without trying to repair something. But you will see the mobility is finally better than we thought. After these stitches, we make, like in the margin conversion technique, we make stitches from anterior to posterior to close the quality, to close the tendon a little bit. And you see it was not so simple. You have to find the good quality of the interwall. These are parts of the interwall you can close. I think from supraspinatus, the biggest part of the tendon is gone. So now you see, whenever you close this first stitch, it's fantastic. You can close more than 50% of the lesion with one suture. Now we're trying the knots, and then we are very close to the footprint of the major tubercle. You see here with the first stitch, we are very close. And we try now to do it with next stitches to close it more or less 1 centimeter over the footprint. In cases like this, it's quite impossible often to close the footprint, but this is for us the best indication for the pitch-patch, when we can close the footprint just 50% to reinforce the repair. So now we try to knot the sutures from the metallic anchors from the medial row. And so with these sutures, we can pull later and bring the repair over the major tubercle. Now we use all these sutures for later for the suture bridge. And now you can see we have all the medial sutures, and we take from the subscapularis up to the infraspinatus, from each anchor one suture to make a suture bridge with the knotless anchor, with the knotless system. So overall, you can in this system you can bring up to 6 sutures into one anchor. So we now with this knotless anchor, we can pull the repair a little bit lateral. We try to find the best place without too much tension, because the problem is always a little bit also the quality of the tendon. We want to bring it to the bone, but not overstretching, not the medial overstretching. So we make the same with the second sutures in the posterior part, and we achieve so a nice 2 to 3 row repair. In this case, it's a 2-row repair. Often we try to have 3-row repair to bring with this next row the tendon a little bit more lateral to achieve a better footprint coverage. And now we have quite a stiff interface between tendon and bone, and it looks not so bad. But this is just repair, and we know it's a massive rotator cuff here. These are three tendons, 3 muscles that are pulling on the tendon, and that's why now we reinforce the construction with the pitch-patch. The pitch-patch, it's like a strength bypass. It's coming from the muscular tendon's junction to the bone. So the interface of the tendon bone is through with this bypass quite calm and stable. Now you can see we pull in from medial. We put 2 sutures to the medial side in the junction, and we use these sutures to pull in the pitch-patch. And it's very important that the sutures are close to the muscle and not in the tendon, because if it's in the tendon, you have the same mobility on the tendon over the interface to the bone. Now we have these 2 sutures, and we pull in the pitch-patch, and the lateral holes there are 3 sutures. Now we can make the knots medial side. So we pull 1 suture out of the anterior portal, and we can make the knots. And after the medial fixation, you know where the patch is. And you can also measure it. In the first time we measured the insertion points, but with a certain experience, you know how far away you have to be with the stitches. But it's important to be not too close to avoid the dog ear of the patch on this side. With the dog ear, you have always the risk of a lot of crepitation. If the patch is really flat on the repair, the crepitation is it's not a big problem. Now, after the medial fixation, we take the lateral sutures, and we put on the lateral sutures again this knotless anchor, so we can bring the lateral suture and the lateral anchor to a position with perfect tension. You see now the tension is very nice, and with this anchor, not too much tension, and we can bring it in, and you close nicely the repair. We do the same posterior, and after that we have another holes. If you want to reinforce the patch to medial, it could be important. The anterior-posterior fixation is nice to do, but I think from the physical side it's not very important. We do it in general to avoid the mobility from this anterior to posterior. The pitch-patch itself has no elasticity from anterior to posterior, but a little bit from medial to lateral. So you can't over-tension the patch. So this is now the second anchor, and you will see the patch is now nicely closed over the tendon. And after that, now you can start with the single stitches to make to complete the fixation. Okay, I think this is enough. Now, regarding the tendon, we had in this series in 27 cases, 2 tendon massive rotator cuff tears with more than 5 centimeters, or in 23 tendon, 3 tendon tears. Most of the cases was a trauma in the history. The retraction was or mostly in between part 2 and 3, but we avoid fat infiltration more than degrees 2 in more than one muscle. We accepted degrees 2 in 1 of 3 muscles. You can see we have a significant increase in constant score and SSD, like in the older study 10 years before with the older patches. In the first, in the follow-up after 6 months, we had an increase from 40 up to 80. But very interesting, between 4 months and 6 months and 4 years, there was no difference in constant score and SSV. We had, for sure, we had complete re-ruptures. It was important to make these MRI controls, but there was very interesting that between the 6 months re-ruptures and the ultrasound control between 4 and 5 years, there was no new re-rupture. We had just one revision in this group where we had to remove one of the patches and to make a delta flap repair. 6 other patients showed good result, but honestly, till now, 2 of these got now RSA, say 6 years after the operation. There was a significant difference in patients with part 3 and in constant score and SSV, and also significant difference if the patient has Boutalier 2 and more. We had revisions cause of 2 cases of capsulitis osteofibrosis, and we had this one re-rupture where we had to remove the patch. We had 1 patient later cause of a crepitation where we removed the patch, but the tendon was perfectly closed. So regarding the literature till now in massive rotator cuff tears, we have always to deal between 30 to 40% re-rupture rate, and I think with the Pitch-Patch in this area, we have a very good tool to help to achieve better results. So compared to the regular massive rotator cuff repair, it seems to be a better outcome. It seems to be a very good option in augmentation of a bad quality of tendon in revision surgery or massive rotator cuff tear, where you have to deal with the mechanical problem. For sure, the intact reconstruction shows better result than the re-tear, like in all studies, follow-up studies. And the Pitch-Patch itself, as the first, second generation patch, shows excellent results in massive rotator cuff tears. So far, we haven't seen till now not one foreign body reaction on polyester. That's for sure. We will have one day some foreign body reactions, but they are very, very seldom, because polyester is the longest used material in orthopedic surgery or in general surgery. The resorbable patch showed a very little effect of tendon healing. And we think that the patient benefits from the patch application in massive rotator cuff tears. Thank you for your attention, and bye.